What's new with peripartum cardiomyopathy? Philippine Heart Association 43rd Annual Convention and Scientific Meeting. Bringing global trends in cardiology closer to home. What's new with peripartum cardiomyopathy? Albert Hans P. Bautista, MD, FPCP, FPCC. The Medical City. Session. Cardiomyopathy and cor pulmonale. Friday, May 25, 2012, 2 o'clock to 2:30. Sapphire B, Crown Plaza Hotel. Disclosures. Received honorarium for lectures on various cardiovascular topics, hypertension, ACS, antiplatelet/anticoagulation and CHF for various pharmaceutical companies. Received research grants or honorarium for various clinical trials on hypertension, antiplatelet, anticoagulation, ACS and CHF patients for various pharmaceutical companies. Member of the Advisory Board for Thrombosis of Snowphy. Peripartum cardiomyopathy. Session outline. What's new in peripartum cardiomyopathy? Review the cardiovascular changes in pregnancy. Pathophysiology of PPCM. History, P and diagnosis of PPCM. Treatment of PPCM. I did a free text search on PubMed for the search term cardiomyopathy and it yielded over 80,000 hits. I followed this with a search for peripartum which yielded a little over 2,000 hits. The combination of the two search terms with and plus filters for English and human studies narrowed the hits to 269. Still a lot of journals but at least manageable. Looked into what's new and for new therapeutic options. Peripartum cardiomyopathy. Session outline. What's new in peripartum cardiomyopathy? Review the cardiovascular changes in pregnancy. Pathophysiology of PPCM. History, P and diagnosis of PPCM. Treatment of PPCM. And with this PubMed searches, I will be able to at least give you a few what's new or at least something to think about. Cardiovascular changes in pregnancy. To meet the increased metabolic demands of both the mother and fetus 1,2, evident by 5th to 8th WK, peak by late second trimester. Greater than increased blood volume, 40%. Greater than increased CO, 30 to 50%, 80% early postpartum. Greater than decreased SVR and BP, active vasodilation. Greater than increased LV size, 30%, dilatation. Hypercoagulopathy 1. Greater than increased coagulation factors, fibrinogen and platelet adhesiveness. Greater than risk for thromboembolism from venous stasis due to obstructing uterus. 1. Escape guidelines on the management of cardiovascular diseases during pregnancy. European Heart Journal, 2011, 32, 3147 to 3197. 2. Oakley C. et al. ed. Heart Disease in Pregnancy 2nd ed. Massachusetts, Blackwell Publishing 2007 to 6 to 17. Cardiovascular changes in pregnancy. To meet the increased metabolic demands of both the mother and fetus 1,2, evident by 5th to 8th WK, peak by late second trimester. Greater than increased CO, 30 to 50%, benign early systolic ejection murmur. Greater than increased LV size, 30%, dilatation, displaced apex beat. Greater than increased preload. Incorporated BLD volume plus CO. Greater than decreased afterload. Low resistance utero. Placental circulation. Plus vasodilation. 1. Escape guidelines on the management of cardiovascular diseases during pregnancy. European Heart Journal, 2011, 32, 3147 to 3197. 2. Oakley C. et al. ed. Heart Disease in Pregnancy 2nd ed. Massachusetts. Blackwell Publishing 2007-6-17, Peripartum Cardiomyopathy, Pathophysiology. Idiopathic cardiomyopathy presenting with heart failure to injury to LV systolic dysfunction from 1 month antepartum, up to 5 months after delivery, when no other causes of heart failure is evident. 3. Incidence of 1 to 3,000 and 4 to 1 to 40,000 and 5 pregnancies. Predisposing factors: 5, 6, 7. Greater than multiparity. Greater than multiple births. Greater than smoking, diabetes. Greater than pregnancy complicated by preeclampsia, eclampsia or hypertension. Greater than advanced stage or teenage pregnancy. 5. Pearson G. et al. National Heart, Lung and Blood Institute and Office of Rare Diseases, National Institute of Health. Workshop Recommendations and Review. JAMA. 2000, 283, 9, 1183-1188. 6. Sliver et al. Peripartum Cardiomyopathy. Lancet. 2006, 368, 9536, 687-693. 7. Damakis J.G. et al. Natural Course of Peripartum Cardiomyopathy. Circulation. 1971, 44, 6, 238-244. 3. Elliott P. et al. Classification of the Cardiomyopathies, a position statement from the European Society of Cardiology Working Group on Myocardial and Pericardial Diseases. Year Heart J 2008, 29, 270-276. 4. Fett J.D. et al. 5-year prospective study of the incidence and prognosis of peripartum cardiomyopathy at a single institution. Mayo Clinic 2005, 80, 12, 1602-1606, Peripartum Cardiomyopathy, Pathophysiology. Etiology 8, Plausible etiologic mechanisms. Greater than myocarditis. Greater than apoptosis and inflammation. Greater than abnormal immune response to pregnancy, chimerism. Greater than maladaptive response to hemodynamic stresses of pregnancy. Greater than others, prolactin. 8. Johnson Coyle L. et al. Peripartum Cardiomyopathy, Review and Practice Guidelines. AMJ Critical Care 2012, 21, 2, 89-98. Peripartum Cardiomyopathy, Pathophysiology. Etiology, Plausible etiologic mechanisms. Viral myocarditis, Cooley et al. 1937. Greater than 8.8 to 78% prevalence of myocarditis in PPCM 9, 10. Greater than endomyocardial biopsy shows lymphocytic infiltrates with myocytic edema, necrosis and fibrosis 11. Apoptosis and inflammation. Greater than programmed cell death. Greater than increased concentration of plasma cytokines, tumor necrosis factor A, SHE and FAS/APO1, cell surface protein ligand role in apoptosis 12. Greater than no significant correlation has been demonstrated to LV function 13. 9. Midi-IMG et al. Peripartum myocarditis and cardiomyopathy. Circulation. 1990, 81, 922-928. 10. Ryzik M.N. et al. Incidence of myocarditis in peripartum cardiomyopathy. AMJ Cardiol. 1994, 74, 474-477. 11. Melvin K. et al. Peripartum cardiomyopathy due to myocarditis. N. Engel J. Med. 1982, 307, 12, 731-734. 12. Sliver K. et al. Peripartum cardiomyopathy. Analysis of clinical outcome, LV function, plasma levels of cytokines and FAS/APO1. J. M. Cole Cardial. 2000, 35, 3, 701-705. 13. Van Heaven K.H. et al. Peripartum versus Idiopathic Cardiomyopathy in Young Women, a comparison of clinical, pathological and prognostic factors. In J. Cardiol 1993, 41, 57-65. Peripartum Cardiomyopathy, Pathophysiology. Etiology, plausible etiologic mechanisms. Abnormal immune response to pregnancy, chimerism. Greater than fetal microchimerism, harboring, of fetal cells in maternal circulation 14. Greater than natural immunosuppression lost after delivery, and if the fetal cell 5, 6, 14, 15, 16 happen to be on the cardiac tissues. Pathologic autoimmune response PPCM. Maladaptive response to hemodynamic stress of pregnancy. Greater than incorporated BLD volume incorporated CO incorporated preload, DEC afterload brief and reversible LV hypertrophy to meet the demands of pregnancy. Greater than transient LV dysfunction during the third trimester and early postpartum resolves shortly after birth 16. Greater than there is an exaggerated decrease in LV function when these hemodynamic changes occur 5. Pearson G. et al. National Heart, Lung and Blood Institute and Office of Rare Diseases, National Institute of Health. Workshop Recommendations and Review. JAMA. 2000, 283, 9, 1183-1188. 14. Ansari et al. Autoimmune mechanism as basis for human peripartum cardiomyopathy. Clonrever and Allergy Immunal. 2002, 23, 301-324. 15. Hilfiker-Kleiner D. et al. Peripartum cardiomyopathy, recent insight in its pathophysiology. Trends Cardiovasc Med. 2008, 18, 5, 173-179. 16. Nchusi N.B. et al. Etiology and Risk Factors of Peripartum Cardiomyopathy, a systematic review. In J. Cardiol. 2009, 131, 2, 168-179. Peripartum Cardiomyopathy, Pathophysiology. Etiology, plausible etiologic mechanisms. Others, prolactin. Greater than increased mammary gland secretion. Greater than new proposed mechanism, excessive prolactin production. Greater than incorporated prolactin associated with colon 17. Increased blood volume. Decreased BP. Decreased angiotensin responsiveness. Decreased water, serum R and K levels. Increased erythropoietin equals incorporated HCT. Greater than oxidative stress enhanced D activity and incorporated prolactin cleavage in acute peripartum cardiomyopathy 17. Greater than correlation BET-proBNP, prolactin, oxidized LDL and interferon Y18. 17. Hilfiker-Kleiner D. et al. A cathepsin D-cleaved 16-KD form of prolactin mediates peripartum cardiomyopathy. Cell. 2007, 128, 3, 589-600. 18. Forstro, et al. Reversal of IFN gamma, oxalate, and prolactin serum levels correlate with clinical improvement. In patients with peripartum cardiomyopathy. Year J. Heart fail. 2008, 10, 861-868. Peripartum cardiomyopathy, History and P. Clinical manifestations: 5, 19, 20, 21. Dyspnea, sob, dizziness, F, orthopnea. Chest pain, palpitations, cough. BP, left lateral recumbent. Neck, heart. Greater than NVE greater than soft S1, S3, S4, M changes in M. Lungs, extremities. Greater than rails, bibasal, greater than bipedal edema. Abdomen. Greater than hepatomegaly, hepatojugular reflux. Arrhythmia IEAF. Embolic events due to dysfunctional dilated LV. 5. Pearson G. et al. National Heart, Lung and Blood Institute and Office of Rare Diseases, National Institute of Health. Workshop Recommendations and Review. JAMA. 2000, 283, 9, 1183-1188. 19. Rowe et al. Peripartum Cardiomyopathy. Cardiac Rev 2006, 14, 1, 35-42. 20. Ramaraj R. et al. Peripartum Cardiomyopathy, Causes, Diagnosis and Treatment. Clevclin J. Med. 2009, 76, 5, 289-296. 21. Williams J. et al. Critical Care in Obstetrics, Pregnancy-Specific Conditions. Best Practice Clin Obstet Gynecal. 2008, 22, 5, 825-846. Peripartum Cardiomyopathy, Diagnosis. Evaluation, 8, 20. Blood, CBC, electrolytes, BUN, CREA, SGPT, SCOT, cardiac enzymes, BNP, proBNP, plus urinalysis. CXR, pulmonary edema, pneumonia. 12 liters ECG. Greater than 5 to 20 L-axis deviation, transient NSST-TWCs, LVH. Echocardiogram serial evaluation. Greater than assess cardiac function, structural integrity. Greater than chamber dimensions. Greater than valvular function. Greater than wall motion abnormalities, global hypokinesia. Others, CBG, thyroid function test, ultrasound, CT scan, MRI. Diagnostic criteria. 8. Johnson Coyle L. et al. Peripartum Cardiomyopathy, Review and Practice Guidelines. AMJ Critical Care 2012, 21, 2, 89-98. 20. Ramaraj R. et al. Peripartum Cardiomyopathy, Causes, Diagnosis and Treatment. Clevclin J. Med. 2009, 76, 5, 289-296. Peripartum Cardiomyopathy, Diagnosis. Evaluation, 22. Diagnostic criteria. Greater than heart failure developing in the last month of pregnancy or within 5 months of delivery. Greater than no identifiable cause of heart failure. Greater than no recognizable heart disease before the last month of pregnancy. Greater than echo parameters. F less than 45% or F's less than 30% plus or VED greater than 2.7 cm/m2. 22. Hibbard et al. A modified definition for peripartum cardiomyopathy and prognosis based on echocardiography. Obstet Gynecal 1999, 94, 311-316. Peripartum Cardiomyopathy, Treatment. Peripartum Care, 1. Joint Obstetric and Cardiac Care, Perinat/Neonate. Consider urgent termination of pregnancy in refractory HF. Vaginal delivery preferred, CS as obstetrical indication. Lumbar epidural analgesia. LL recumbent during labor. Avoid to push, assisted by forceps delivery. Systemic arterial pressure monitoring, fetal monitoring, SWAN is rarely needed. 1. Escape guidelines on the management of cardiovascular diseases during pregnancy. European Heart Journal, 2011, 32, 3147-3197. Peripartum Cardiomyopathy, Treatment. Peripartum Care, 5, 21, 23. HF treatment as per guidelines. Similar to other forms of heart failure. Careful attention to A. Fetal safety. B. Drug excretion. C. Drug metabolism. Goals. Greater than improve hemodynamic status. Greater than minimize signs and symptoms. Greater than optimize long-term outcome. Focus. Greater than reducing preload and afterload. Greater than increasing/improving cardiac inotropy. 5. Pearson G. et al. National Heart, Lung and Blood Institute and Office of Rare Diseases, National Institute of Health. Workshop Recommendations and Review. JAMA. 2000, 283, 9, 1183-1188. 21. Williams J. et al. Critical Care in Obstetrics, Pregnancy-Specific Conditions. Best Practice Clin Obstet Gynecal. 2008, 22, 5, 825-846. 23. Tidswell M. et al. Peripartum Cardiomyopathy. Critical Care Clin. 2004, 20, 777-788. Peripartum Cardiomyopathy, Treatment. Peripartum Care, 8. Hospitalization due to A. Hypotension. B. Worsening HF. C. Altered mental status. D. Incorporated work of breathing, pull edema. Management. Greater than vasodilators/unloaders, ACE/ARB, C. Nitrates, hydralazine. Diuretics. Greater than fluid restriction, NA restriction. Greater than CBR. 8. Johnson Coyle L. et al. Peripartum Cardiomyopathy, Review and Practice Guidelines. AMJ Critical Care 2012, 21, 2, 89-98. Peripartum Cardiomyopathy, Treatment. Postpartum Care, 8. Focus. Greater than reducing preload and afterload. Greater than increasing/improving cardiac inotropy. Medications. 1. ACE/ARB-Capto, Enal, Cand, Velsar, Los, Telmi. 2. Digoxin. 3. Diuretics, furosemide/spironolactone. 4. BB, metoprolol, carvedilol. 5. Inotropes, dobutamine, dopamine, milrinone, levosimendan. 6. Anticoagulation, LMWH/UFH/warfarin ASA, Warsef 24. 7. Others. Cardiac support options: A. Intra-aortic balloon pump. B. LV assist device. C. Cardiac transplantation equals 4% of ppcm. 8. Johnson Coyle L. et al. Peripartum Cardiomyopathy, Review and Practice Guidelines. AMJ Critical Care 2012, 21, 2, 89-98. 24. Homer S. et al. Warfarin and aspirin in patients with heart failure and sinus rhythm. N. Engel J. Med. 2012, 366, 20, 1859-1869. Peripartum Cardiomyopathy, Warsef Study. Warfarin and aspirin in patients with heart failure and sinus rhythm. Homer S. et al. N. Engel J. Med. 2012, 366, 20, 1859-69. Warsef Warfarin vs. aspirin in reduced cardiac ejection fraction. Hypothesis: is warfarin superior to aspirin alone for patients with heart failure who are in sinus rhythm? P. 2305 HF patients less than 35% with sinus rhythm. I. Warfarin, 1163, versus ASA 325 mg, 1142. O. First event of composite endpoint of ischemic stroke. Intracerebral hemorrhage and death. M. Double-blind randomized clinical trial. W. INR equals 2 to 3, A. 325 mg odd. 24. Homer S. et al. Warfarin and aspirin in patients with heart failure and sinus rhythm. N. Engel J. Med. 2012, 366, 20, 1859-1869. Peripartum Cardiomyopathy, Warsef Study. P. 2,305 HF patients less than 35% with sinus rhythm. I. Warfarin, 1,163, versus ASA 325 mg, 1,142. O. First event of composite endpoint of ischemic stroke. Intracerebral hemorrhage and death. M. Double-blind randomized clinical trial, W. INR equals 2 to 3, A. 325 mg odd. Results. Greater than primary outcome, HR equals 0.93, 0.7 to 1.10, NS. Greater than ischemic stroke, W, HR equals 0.52, 0.33 to 0.82, P equals 0.005. Greater than major hemorrhage, W, HR equals 2.1, 1.4 to 3.1, P less than 0.001. Conclusion. Greater than patients with HF plus sinus rhythm warfarin reduces risk of ischemic stroke but at a cost of increased major hemorrhage. Greater than no significant difference between ASA and warfarin in their composite endpoint of death, ischemic stroke and IC bleed or HF. Hospitalization. Greater than no compelling reason to use warfarin over aspirin for patients with systolic heart failure and sinus rhythm. 24. Homer S. et al. Warfarin and aspirin in patients with heart failure and sinus rhythm. N. Engel J. Med. 2012, 366, 20, 1859 to 1869. Peripartum cardiomyopathy, treatment. Postpartum care. Medications: 20. 7. Others, in refractory heart failure, limited data. A. Pentoxifylline, improve outcomes, LV function/S and S. Before immunoglobulin, improved F, reduced levels of inflammatory cytokines. C. Immunosuppressive therapy, no proven role but could be tried improve in viral myocarditis. D. Bromocriptine 25. E. Others, monoclonal antibodies, interferon, therapeutic. Apheresis, cardiomyoplasty. Cardiac support options: A. Intra-aortic balloon pump. B. LV assist device. C. Cardiac transplantation equals 4% of PPCM. 20. Ramaraj R. et al. Peripartum cardiomyopathy, causes, diagnosis and treatment. Clevclan J. Med. 2009, 76, 5, 289 to 296. 25. Slivak et al. Evaluation of bromocriptine in the treatment of acute severe peripartum cardiomyopathy. A proof of concept pilot study. Circulation. 2010, 121, 1465 to 1473. Peripartum cardiomyopathy, bromocriptine study. Evaluation of bromocriptine in the treatment of acute severe peripartum cardiomyopathy, a proof of concept pilot study. Slivak et al. Circulation. 2010, 121, 1465 to 1473. Hypothesis: prolactin, mainly 16-chter angiostatic and proapoptotic form, initiates and arrives PPCM, and that early pharmacologic blockade of prolactin with bromocriptine may improve the patient's condition before irreversible cell damage sets in, looked into as HF therapy to improve of functional class and survival in women with acute severe PPCM. P. 20 PPCM patients less than 35% with SPP greater than 95 less than 160/ or DBP less than 105. I. PPCM standard 10 versus PPCM BR 10. O. Composite endpoint of death, NIHA class 3/4. Of less than 35% at 6 months. M. Prospective randomized open-label clinical trial. PPCM standard, enalapril, carvedilol, furosemide, warfarin. ppcmbr, standard plus 2.5 mg bidex 2 weeks, 2.5 mg odex 6 weeks. 25, Slivak et al. Evaluation of bromocriptine in the treatment of acute severe peripartum cardiomyopathy. A proof of concept pilot study. Circulation. 2010, 121, 1465–1473. Peripartum Cardiomyopathy, bromocriptine study. P. 20 ppcm patients less than 35% with SPP greater than 95 less than 160/ or DBP less than 105. I. ppcm standard 10 versus ppcmbr 10. O. Composite endpoint of death, NIHA class 3/4. Of less than 35% at 6 months. M. Prospective randomized open-label clinical trial. ppcm standard, enalapril, carvedilol, furosemide, warfarin. ppcbr, standard plus 2.5 mg bidex 2 WKS, 2.5 odex 6 WKS. Results. Greater than similar in baseline characteristics, BP, labs, LVT/LVST, LV. Greater than changes in NT-proBNP, 16-kDa prolactin and cathepsin D equals NS. Greater than changes in S or DBP and LVT/LVST equals NS. 25, Slivak et al. Evaluation of bromocriptine in the treatment of acute severe peripartum cardiomyopathy. A proof of concept pilot study. Circulation. 2010, 121, 1465–1473. Peripartum Cardiomyopathy, bromocriptine study. Results. Greater than recovery of F, 31% better for ppcmbr, 2758%. ppcm standard, 27% 36%, p equals 0.012. Greater than primary outcome, ppcmbr patients better outcome, p equals 0.006. 25, Slivak et al. Evaluation of bromocriptine in the treatment of acute severe peripartum cardiomyopathy. A proof of concept pilot study. Circulation. 2010, 121, 1465–1473. Peripartum Cardiomyopathy, bromocriptine study. Results. 25. Greater than recovery of F, 31% better for ppcmbr, 2758%. ppcm standard, 27% 36%, p equals 0.012. Greater than primary outcome, ppcmbr patients better outcome, p equals 0.006. Conclusion. Greater than addition of bromocriptine to standard HF therapy appears to improve LV, functional class and survival in women with severe acute PPCM with no obvious detriment to their children at 6 months of study. Greater than beneficial effects said to result from eliminating detrimental effects of 16-kDa prolactin form. Greater than off-target effects on hemodynamics 26, 27. Increase in BP, vascular resistance, plasma norepinephrine levels. Increase SVI, decrease LV filling pressure. Greater than caution. Reports of stroke, seizure, coronary artery thrombosis and coronary vasospasm in normal women. 25, Slivak et al. Evaluation of bromocriptine in the treatment of acute severe peripartum cardiomyopathy. A proof of concept pilot study. Circulation. 2010, 121, 1465–1473. 26, Francis et al. The effects of bromocriptine in patients with congestion heart failure. Amhart J. 1983, 106, pt1, 100–106. 27, Goldberg Lee, et al. The role of dopamine receptors in the treatment of congestive heart failure. J. Cardiovasc Pharmacal. 1989, 14, Supple 5, S19 S27. Peripartum Cardiomyopathy, Prognosis. Treatment duration, continued until recovery of LV function. 6 to 12 months or lifetime. Usually return to normal heart size within 6 months. 30 to 50% recover baseline LV function within 6 months. 16, 28. Prognosis is positively related to recovery of LV function. 16. Failure of LV size to return to N is associated with incorporated M and M5. Minus 94% survival rate in 5 years. 29. Mortality vary, 0 to 9%, 15% for. Recurrence risk in subsequent pregnancies equals 30 to 50%. 4. Fett J.D. et al. 5-year prospective study of the incidence and prognosis of peripartum cardiomyopathy at a single institution. Mayo Clinic 2005, 80, 12, 1602 to 1606. 5. Pearson G. et al. National Heart, Lung and Blood Institute and Office of Rare Diseases, National Institute of Health. Workshop Recommendations and Review. JAMA. 2000, 283, 9, 1183 to 1188. 16. Nchusi N.B., et al. Etiology and Risk Factors of Peripartum Cardiomyopathy, a Systematic Review. Int J. Cardial. 2009, 131, 2, 168 to 179. 28. Aboud J. et al. Peripartum Cardiomyopathy, a Comprehensive Review. Int J. Cardial. 2007, 118, 3, 295 to 303. 29. Felker G. M. et al. Underlying Causes and Long-Term Survival in Patients with Initially Unexplained Cardiomyopathy. N. Engel J. Med. 2000, 342, 1077 to 1084. Peripartum Cardiomyopathy, Prognosis. Predictors for normalization: 30, 31. A. LV less than 55 mm. B. LV greater than 27%. Predictors for persistent LV dysfunction: 30, 31, 32. A. TROP-T, measured 2 weeks after onset, equals inversely correlated with LV function at 6 months, greater than 0.04 nanograms/ml, SN equals 55%, SP equals 91%. B. Fs less than 20%. C. LVED greater than 56 to 60 mm. F is the strongest predictor of outcome. 12. Sliver K. et al. Peripartum Cardiomyopathy, Analysis of Clinical Outcome, LV Function, Plasma Levels of Cytokines and FAS/APO1. J.M. Cole Cardial. 2000, 35, 3, 701 to 705. 30. Dorbala S. et al. Risk Stratification of Women with Peripartum Cardiomyopathy at Initial Presentation. A dobutamine stress echocardiography study. J.M. Sock Echocardiogram 2005, 18, 45 to 48. 31. Duran N. et al. Predictors of Prognosis in Patients with Peripartum Cardiomyopathy. Int J. Gynecolabstet 2008, 101, 137 to 140. 32. Hucel, et al. Troponin T measurement can predict persistent left ventricular dysfunction in peripartum cardiomyopathy. Hart 2007, 93, 488 to 490. Peripartum cardiomyopathy, prognosis. Counseling. Recommendation for subsequent pregnancy. Greater than do deeps to measure maximal inotropic contractile reserve. Correlated with subsequent recovery of LV function. Recommendations: 30. A. If LV function recovered fully, subsequent pregnancy not C but should be warned of recurrence. B. If partial LV function recovered, perform the DEEPS :30. In response, appropriate augmentation, pregnancy not C but warned. AB response, risk is moderate, subsequent pregnancy C. C. If LV function not recovered, subsequent pregnancy C. 30. Dorbala S. et al. Risk stratification of women with peripartum cardiomyopathy at initial presentation. A dobutamine stress echocardiography study. JM-SOC Echocardiogram 2005, 18, 45-48. Peripartum cardiomyopathy, summary. Peripartum cardiomyopathy is distinctly defined, albeit a diagnosis mostly by exclusion with its criteria. Plausible etiologic mechanisms make it difficult for targeted treatment regimen. Treatment is based on HF guidelines, with the goal of improving hemodynamic status, focused on reducing preload, afterload and increasing cardiac inotropy with careful attention to fetal safety, drug metabolism and excretion. Peripartum cardiomyopathy, summary. Provide standard HF care, ASA recommended, and bromocriptine is a new option for intractable HF. Mortality varies up 15%, but overall prognosis is good with more than 90% survival rate in 5 years. Predictors for prognosis should be used when counseling patients regarding subsequent pregnancy who are at high risk for recurrence.